First, thank you very much for this opportunity, and it is an honor for me to talk here with you and every other speaker because, well, I'm from Indonesia, and Indonesia is quite a far country from India, sure. I will show you first. I come from Samarinda, and Samarinda is around here in the center of Indonesia. I'll talk about how we perform retrograde intrarenal surgery in Samarinda. First, we do it in 2014. Per year, we perform around 400 RIRS per year. We use the Luminis 100 watt. First, we use the wolf fiber scope, and we use access seat from the start because at that time, we find it very difficult to insert the flexible ureteroscope without the access seat. The first flexible ureteroscope lasted for only 10 procedures. It was broken because I force flexed it inside the renal calyx. But we are very lucky the hospital can provide us the new one. Now we use the Olympus and also the Wolf and also the disposable flexible ureteroscope for teaching purposes and backup. The Olympus flexible ureteroscope has a small defect after a 320 procedure, get repaired, and we can still use it until now. And at the beginning, we use it for all our renal stone because we don't have ESWL in Indonesia and in my city, I mean in my hospital. But now we only use it for small stones, smaller than 4 centimeters with the hardness less than 1,000 Hounsfield unit. And this is our flexible ureteroscope that we use right now. This is the settings. I mean, this is the things that we use now. I really love to use the 365 fiber because it can give a bigger power, so I can finish the job faster. We also perform supine BCNL and RIRS for the renal stone management. For big renal stone, for complete Staghorn stone, we will perform supine PCNL and RIRS for complex stones. And this is the indication. I will show you about the recommendation in the AUA. It is for the stone, renal stone, more than 20 millimeters, the first line is PCNL. And in EAU, also the first line is PCNL. But in the EAU guideline, URS, that's the flexible ureteroscopy also, is included for the second line. And the lower pole, for the more than 20 millimeter stones, also the RIRS becomes the second line. Some patients choose to underwent RIRS instead of PCNL. This is a quick review of how we do it. We like to do brushing with the highest frequency possible with very low power, and also drilling with the high frequency possible to the highest power, and popcorning with the low frequency and the high power. And I will show you the case. I think Vinith have seen this case also because this is interesting. A male, 50 years old, come to the clinic with chief complaint of the pain in the right flank, and the NCCT showed a right renal stone from pilum to the lower pole, 3.8 centimeters in the longest part, 765 Hounsfield unit. This is the stone, a very nice stone. And the choices are PCNL, RIRS, RIRS, and open surgery. In my hospital, we have 4 urologists, and we have a commitment that we don't do open surgery for stone unless it is very, 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 very complex stone. And for this stone, what shall we do? Well, At this stone, I use our retrograde internal surgery with my flexible uteroscope. And I remember doing this for about 1.5 hours. And this is the after the procedure. This is when we do it. You see, this is in the pilum. We use the semi-rigid ureteroscope first. Okay, now I'll talk about the key points of doing it in my place. We have to use the appropriate device, and we have to use the appropriate settings. I will always use urethral access seat in big stones like this. I always use the semi-rigid ureteroscope first. We'll talk about it later. And irrigate using saline, using syringe. I don't use the irrigation devices because I believe that my nurses' hands are very, very capable of giving the view that I need. And patience. I think that's one of the key point. Okay, use the appropriate device. The 100-watt holmium laser from Lumis and instead of the smaller ones, because it can deliver much bigger energy. Well, we see that the smaller laser fiber, like the 220 microns, it can only deliver about 30 watts of energy, and I need bigger energy than that. So I prefer to use the bigger fiber. And well, this is a very important tip. Make sure your blast shield is in good condition. Well, in every holmium laser device, they have the blast shield to protect the laser from firing back to itself. And after some use, the blast shield will become worse, will become darker, and if you have a bad blast shield, then you will ruin your machine, you will ruin your fiber. It will cost you a fortune. So make sure your blast shield is in good condition. Like this, we have the big power, so we can do it very fast. Okay, use the appropriate settings. The bigger the power, the faster the laser fiber out. Well, of course. And the higher the frequency, the faster the work done. That's why I love to do it in a high frequency. I usually do the dusting 0.2, 0.4 joule with 50 hertz, and drilling with 0.8, 1.4. With 40 to 50 hertz, and drilling and popcorning around 1.4 joule and 30 hertz. And I always use urethral access seat for this. Why? Because it's going to be quite a long procedure. Well, I actually limits my procedure in retrograde intraanal surgery to 1 to 2 hours, depending on the patients. Because if it's more than that, then we will have more complications. And if I predict the surgery will be longer, I will always use the urethral access seat. And urethral access seat will keep your flexible ureteroscope alive for a longer time. The urethral access seat is very useful if you need to use the basket frequently. But the downside is sometimes pre-stenting is needed. In my place, we do pre-stenting in around 40% of the patient right now because we cannot insert the urethral access seat at the first attempt. When we cannot insert the urethral access seat for the first attempt, I don't do the dilatation of the ureter, but I will just insert the digestan and I will come back 2 to 4 weeks after that. And also there's a risk of urethral injury. But if you do it smoothly, we can do it very safe. And I always use the semi-rigid ureteroscope first. Use it to break the visible part of the stone in the piellum. And this will keep our flexible ureteroscope, which is an expensive one, healthy for a longer time. We can use a small semi-rigid ureteroscope inside an access seat to keep the intrarenal pressure low. That's very important. Like this, we can see that, well, this is the piellum, and this is the kidney, this is the stone. When we use the rigid, semi-rigid ureteroscope, we will do this part first. We will do this part first with the semi-rigid ureteroscope, and we will do this part using the flexible ureteroscope. So it will keep the flexible ureteroscope working longer. I remember, I think Vinit, you still remember when I showed this picture when in Penang, I think Henry comment about this yoga position of the flexible ureteroscope. Yes, to achieve this, we need to do the passive deflection. So we can put our access seat and push it along with the flexible ureteroscope. We can see here there is a passive part that can be deflect, and the active part. Many of the urologists that use the flexible ureteroscope only think about the active deflection part, and it will limit your access. If we think about the passive deflection part also, you can reach difficult position of the stones. The passive position here. And patience. Well, I can feel that if we do PCNL, we can do it very fast. Take the stones, then it's done. But retrograde internal surgery is actually, for me, it's a kind of art. Art in sense of we do it smoothly, we have to do it patiently, and we will love the results. So my second message is patient selection. Like the first, the early slides that I given, the patient selection is very important. If the stone is harder than 1,000 hospital unit, don't do it. Use PCNL instead. And do it with a semi-rigid ureteroscope until it is impossible to break the stone using it. Then use the urethral access seat so you can work in longer time and keep the kidney safe because the intrarenal pressure will be kept low. And use the appropriate setting from brushing, drilling, popcorning, and be patient. Again, be patient. This is an art. You see, this is the stone, and we do the RIRS into that, retrograde internal surgery, and this is the final outcome. And I'll show you one more. This is a bit smaller than the previous stone. This is an old lady. I think she was 70 years old, an old lady. And we also perform retrograde intrarenal surgery to her. And I like to show this because if you see this, you will see, we will say this is residual stone. No, because after 4 weeks, this is what we get. See? It's not residual. It will flush. It will be flushed. Thank you for the opportunity. I'm honored. Thank you, Vinit.